Good morning. First of all, I'd like to thank the organizers, Sudeep sir and Shona ma'am, for giving me an opportunity to present these abstracts. So today in this session on loco-regional breast cancer, I'm going to present 3 abstracts. The first one is about identifying patients whose symptoms are under-recognized during treatment with breast radiotherapy. This was published in JAMA Oncology and Reshma Jagsi is the lead author. Now this study was carried out in post-lumpectomy patients who underwent adjuvant radiotherapy. And during radiotherapy, the physicians evaluated the toxicity using the CTC criteria. Patient-reported outcomes were also assessed weekly using the brief pain inventory and Skindex. 72% patients were able to complete at least one PRO questionnaire, and all of these questionnaires were then matched to the physician-assessed CTC, which were carried out within 3 days. And what was observed was that there was a significant under-recognition of symptoms in the range of 40 to 50% for symptoms like pain, pruritus, edema, and fatigue by the physicians. And if we look at the factors which were associated with this under-recognition, younger patients, black races, races other than white, use of conventional fractionation, and male sex of the physician were associated with significant under-reporting. So this study concluded that physicians can miss substantial symptoms and therefore PROs are essential for trials. Improving symptom detection can help to reduce disparities in experiences and outcomes. Now, though this study mentioned about the gender of the physicians, it did not mention about the race or the ethnicity of the physicians as compared to the patients. The PROs were reported in terms of the frequency, and they were compared with the CTC outcomes which were reported in terms of the severity. So the common PRO questionnaires which actually measure the severity, that is the EORTC, BR23 and FACT-B, were not used. Now these patients are pre-treated who have already received surgery and undergone surgery and chemotherapy, and therefore a baseline information about their pain and fatigue is important, and it was not available in the study. So the take-home message is that we all know that disparities do exist for symptom assessment. While in US, it may be related to race and ethnicity. If we look in India, we have a tendency to underreport the symptoms for patients who are illiterate and those with low socioeconomic status, probably related to a communication gap. And it also depends upon the time spent by the physicians in assessing these symptoms. So definitely PROs, they improve the toxicity data and should be included in the trials. Engagement of the interdisciplinary team helps to improve communication, symptom detection, and supportive care, and thus it can optimize cancer care. The second study is about the use of comparison of supine versus prone breast radiotherapy on acute toxicity of the skin among women with large breast sizes. This randomized clinical trial was published in JAMA Oncology, and Danny Vesperini is the lead author. Now this was a phase 3 multicentric single-blind randomized control trial. It included patients only with large breast size, which was defined as a bra band of 40 inches or a cup size of D. Patients were randomized to prone or supine position. Only breast radiation was allowed by IMRT, and regional nodes were not irradiated. The first cohort of the patients in both the groups, they received conventional fractionation. But subsequently, in the middle of the trial, there was a trial amendment, and they began to use a hypofractionated schedule of 3 weeks. And both the patients in both the groups then subsequently received hypofractionation. The skin toxicity was assessed by the physicians at baseline, weekly during treatment, and 6 to 8 weeks post-treatment using the CTC criteria. Whereas the patient-reported outcomes were recorded at baseline during the last week of radiation and 6 to 8 weeks of follow-up using the EORTC core questionnaire and the BR23. Clinical research assistants were blinded to the arm, and they assessed the acute toxicity independent of the physicians. So if we look at the moist desquamation of any grade or moist desquamation of grade 3, the desquamation was significantly low in patients treated in the prone position as compared to the supine position. And if we look at the factors which were associated with moist desquamation on the multivariate analysis, supine position, large breast sizes, delivery of a boost, and use of extended fractionation over hypofractionation significantly increased the moist desquamation. So this study concluded that prone position decreases the desquamation in women with large breast sizes, and increased toxicity is seen when we use a boost or conventional fractionation over hypofractionation. Now, though the study tried to compare hypofractionation with standard fractionation, it was underpowered to do so, because hypofractionation had been introduced in the middle of the trial as a part of the trial amendment. There is a lack of standardization over the bra band or the cup sizes, so using them as a predictor of breast volume or toxicity is not justified. Fractionation appeared to be a stronger predictor of moist desquamation than treatment position. And we all know that with the prone setup, there is definitely more homogeneity in the dose delivered, and it also reduces the lung doses. However, the prone position tends to pull the heart anteriorly towards the chest wall, closer to the beams. So data is mixed whether the prone position decreases or increases the cardiac doses. Also, prone position requires a larger expansion from the CTV to the PTV. The delivery of boost in the prone position or regional nodal irradiation remains an area of investigation. If you look at the patient comfort, majority of the patients, they report a preference for the supine position. So the take-home message is for patients with large breast sizes and right-sided breast cancer, prone position definitely decreases the skin toxicity and it also decreases the lung dose. However, for patients with left-sided breast tumor and large breast sizes, prone position does reduce the skin toxicity, but we are not sure about the cardiac doses, especially if we compare them with the supine DIBH. So therefore, in women with left-sided breast cancer with large breasts, prone position should be preferred only if one can meet the cardiac constraints. Now the third abstract, hypofractionated radiotherapy in patients with breast cancer, acute toxicity data of a phase 3 trial. Now this study was presented at the San Antonio 2022 by Dr. Buddhi Singh. Now this study tried to compare two arms of hypofractionation. One was the standard arm of a 3-week schedule, 40 gray in 15 fraction 3 weeks, and the other was a 2-week schedule of 34 gray in 10 fractions. Boost, if required, was delivered in both the arms with 8 gray in 2 fractions, and patients were planned on a simulator using 2D planning, using 2 tangential fields for the breast or the chest wall, and a supraclavicular and internal memory field when required. If we look at the patient characteristics, it was a typical real-world data. It included all T stages. T4 patients were nearly 100 in each arm. All N stages were included, and nearly 50% of the patients had received neoadjuvant chemotherapy. If we look at the surgery, we can see that nearly 75% of the patients had undergone mastectomy, and breast conservative surgery could only be done in 20 to 25% of the patients. The supraclavicular fossa was irradiated in nearly 85% of the patients, and internal memory nodes were irradiated in 40 to 45% of the patients. Separations as wide as 26 centimeters were allowed in this study. Now, when we look at the acute toxicity, the skin toxicity appeared to be comparable between the 3-week and the 2-week schedule. And the cosmesis, which was reported using the Harvard scale, was reported as superior in the 2-week schedule as compared to the 3-week schedule. So the author concluded that the 2 radiation schedules of 3 weeks and 2 weeks were comparable in terms of the acute skin toxicity. The cosmetic outcome was better in the 2-week schedule. Now, the major drawback of this study is that it was a 2D-based planning, and they used 2 tangentials, and they also included supraclav and internal memory nodes even with a 2D planning. Dose per fraction for the breast or the chest wall was 3.4 per gray, and for the boost, it was 4 gray. So moderate hypofractionation is anything less than 3 gray. So these doses were very high, and if we look at the boost, it almost goes in the range of ultra hypofractionation. In spite of using such high doses, nothing has been mentioned about the dosimetry, the cardiac doses, the lung doses, the contralateral breast dose, and even the maximum heart distance, which is used as a parameter to assess the cardiac doses in the 2D planning, was not mentioned. Separations as wide as 26 centimeters were allowed, and using 2 fields with the tangents to achieve a good dose conformity or homogeneity with this wide separation is not feasible. If we look at the alpha beta for the late effects, the BED was with the boost as high as 90 gray. So without a volume-based planning, the late toxicity needs to be followed up closely. Cosmesis was reported to be superior using the Harvard scale, but the Harvard scale is used for intact breast, and patients with BCS constituted almost 25% or less than that. So combining the mastectomy patients with the BCS patients, where mastectomy accounted for 75% and then reporting the cosmesis as superior is not justified. So the take-home message is that moderate hypofractionation currently at less than 3 gray per fraction is the standard, It is equally effective, less toxic, less costly. It is indicated for all indications, yet the acceptance in our country remains low. Ultra-hypofractionation is still evolving. We are waiting for the long-term data, and therefore it should only be used for selected patients with a volume-based planning and a patient consent. Thank you.